Our next speaker is Sue Brownlowe, who's the manager of the chronic care team at the Agency for Clinical Innovation, and has a clinical and health management background, having worked in the public health system for over 30 years, particularly with aged and chronic care. We'll look to you now to talk about the chronic disease management program.
Yeah, that's fine. Thanks, Annette. I'd like to acknowledge the traditional owners of the land and elders that we're meeting on today, and the lands that everyone's come from, and also thank Annette and Kate and Wilson for the opportunity to come along today and talk about the chronic disease management program. Connecting Care in the Community, some people may know it as Connecting Care, which was when it first commenced back in 2010 was the name of by which it went by at the time, and is still often referred to. So for the purposes of today, and I did have privy to the attendance list prior, I'm just going to give an overview of the chronic disease management program for those people that may not be so familiar with it, and then the back end of it will be looking at some of the strategies that that the chronic disease program offers, and that particularly would have a readmission flavour for it. Okay, so the chronic disease management program came, on the back of, so since 2000 we've had policies, frameworks and guidelines, and then of course we've had some things like the IPART report, the Garling inquiry, and the National Health and Hospital Reform, and there was a business case put to Treasury in 2009 that released funds to New South Wales Health. And those funds were put out to what were area health services at the time, but then of course we've morphed into, so for the purposes of the presentation I'll always be referring to LHDs, hospital networks, and Medicare locals, bearing in mind that they were GP divisions in the beginning. It is about looking at that, reducing the progression and complications of chronic disease, improving the quality of life for people with chronic disease, but also looking at providing that support for the carers and families in terms of the trajectory that chronic disease does follow, and making sure that people have their optimal care, and also they're leading on to advanced care planning and things, so introducing those sort of topics in. The models that we have are varied, like a couple of presentations have already alluded to. We have 15 LHDs, the hospital network, specialty networks that we are working with are the Sydney Children's Hospital, St Vincent's, and Justice Health and Forensic Medicine. So there are some exceptions needed by virtue of the cohort of that people deal with, but it was also around. It was really recognising that the structure or infrastructure that the LHD had, being a non-prescriptive program, most LHDs went to their strengths. And of course, the effect of the reforms going through this, as we cut across all the sectors, which is what this program does, influenced how that sort of would have rolled out as well. And in terms of this is very much a partnership, and I'll talk a lot about that in the next few slides, is around what those partnerships look like, and how strong they were, or were they newly developing, and things with the Medicare locals coming on board. This is our service model, and I'll keep going backwards and forwards to this across the next few slides. It has some overarching principles. Mostly that's around the partnerships within the public health sector, partnerships within primary care, the non-government sector, and other governments, as well as some private and specialist services. We have some elements which I'll address in the next few slides, and also those resources or enablers, and what part they play and are playing, and where we need to look to develop those as we go forward. It is a targeted program. We were looking at the potentially preventable hospitalisations, and a lot of work had also been informed around integrated and aged care projects that were done back in 2007, 2008, the learnings that we got out of the avoidable admissions as well. So primarily we have, there are 5 large areas: coronary artery disease, heart failure, COPD, diabetes and hypertension, but it's an expanded code. It breaks down to about 20 ICD-10 codes. There's an expanded co-set for Aboriginal people and looking at chronic disease in Aboriginal people, and also that's expanded out for the Justice Health and forensic medicine cohort as well. It is for people that are 16 years of over, 15 years for Aboriginal people, and we're looking at sort of those adult services, and where we get involved with the Sydney Children's Hospital Network and Trapeze is that transition as people are coming out of the PED services into adult services. As well as having that, there's the algorithm that someone's already mentioned was put into the systems, and we're looking 3 or more presentations and or admissions into acute care facilities for those chronic diseases, which sits there as the flag and triggers a number of things, and I'll talk a little bit more about that because that's in most areas real time now. The other thing that we did look at was those predictors of hospitalisation around age, Aboriginality, previous admissions, some other, unhealthy, low income, and some of the other sort of social determinants of health. So we look at that as well as part of the risk stratification. There is a comprehensive assessment. What does that mean? Someone's already said this morning about the number of comprehensive assessments that occur, and that in fact when we profiled the original the data set that came out from New South Wales Health at the time was in fact people could have 4 or 5 plans, but none of those plans necessarily informed each other. They didn't necessarily inform the primary care area of Aboriginal medical services or general practice, and in fact patients did or didn't have them, were confused by them, not sure who the key contact was, depending on what that was. So what CDMP does is it attempts to actually bring all those plans together alongside the general practice or GP, with that GP management plan, if there is one of those in place, or in terms of from the public sector, pulling together some specialty plans to make sure that the GP is actually aware of what they are, and the patient and carer is also aware of what they are. The comprehensive assessment needs to be complete, so there may have been gaps along the way, and it also has to have some recency about it. The endeavour to have a shared care plan, visibility, where we all know what's happening. It's probably our biggest challenge in some ways, because we don't have the systems that talk to each other, and we don't always have visibility from one sector to another, or we probably don't have visibility from one sector to the other. But I mean, these were the chronic disease management program. In some respects, it's been ambitious, as it's gone across the whole of the health sector, but it is around if it's not there in an electronic way, then it could be there in a manual way, and is it shared, and is it about the conversation and bringing those conversations together, which I've heard lots and lots of today. So I've actually felt like one of those those little dogs that sit in the back with a little runny neck at the back of the car, as I've listened to sort of some parts that are working really well, some ways that we're dovetailing, I think from Greg, some validation about the pitfalls and challenges that we too are facing. Care coordination and self-management are really the aims of this program. It's not necessarily, depending on how it's been rolled out in the LHDs and specialty networks, it isn't a new clinical service. It's actually wrapping around that, going out into primary care, being the bridge, the link, whatever words you like to call it, but it is around looking at what is the care coordination component of that, and that self-management strategy with a mind of how we support patients and understanding their disease trajectories, lifestyle and behaviour changes, and also looking at sort of action plans, escalation plans, patient goals. We are working with the primary healthcare sector, so the concept of the person-centred medical home with GPs, AMSs and general practice in its expanded form is critical in this program. A quick profile, and I will, because some of this is around our partnering, is that just under 69, this is at February 2013, we are undergoing a extensive evaluation. I'll talk a little bit about that at the very end. But in 2013, in February, there was just under 69% of our clients enrolled are over the age of 65. Originally, when the program was released, it was actually targeted at 65 and over, but then there was a whole lot of things around the chronic diseases that we were looking at, and particularly like with children, Aboriginal people, that there was a move that we expanded it down to the 16. This slide is probably for me just a bit of a placeholder in a sense, because now I'll start talking about some of the aspects of CDMP that look at readmissions. But I guess this is from the BHI report that was released mid last year. But for 2009 and 10, this is heart failure, but there's a similar graph around readmission rates for COPD. And I guess from my perspective in terms of my role, this is actually a really good marker, because this, going forward for any more studies in this area, is actually when CDMP commenced. So what components around the concept of readmission does CDMP address or attempt to address, or is looking to build on, and I've broken that up into 4 broader areas. So in terms of, like, from an integrated perspective, I guess even being invited here today is part of that, because, you know, this is the acute care task force. Being at the ACI, you have access to all the networks there, so it is about building those relationships even at that level, and where does our work dovetail, and what are the important key messages that need to come across, and, you know, the aspects of where we work together. It is about where CDMP's positioning. It is, as I keep saying, it's across the whole of the health sector. But not only that, it's primary health care. It is the acute care, community health, the NGO, the private sectors, aged care. So we're involved and have been involved with those groups for since our inception, and continue to build up those relationships. The Chronic Care for Aboriginal People program has been very informative as the way that CDMP has embraced some of the strategies, and I will, thanks to Rachel, talk a little bit about how 48-hour follow-up and some of the areas where that has been embedded. But I mean, we work alongside each other. We look that it's the same cohort, and we have to need to work how we get these programs out and across the state. Aged care, I've already talked about the profile. The mental health services, there's some, in some of the LHDs, one in particular, there's a lot of work that's being done with mental health patients, particularly in terms of their readmissions to acute care facilities when they do have a chronic disease, and working in those sort of partnerships together. And of course the transition, as I've talked to, around paediatric children that have been in paediatrics coming into adult services, and what does that mean, because that can be quite challenging, quite different, and where from a chronic disease perspective can that link into CDMP. The readmissions, the flag, as was referred to earlier, is that 3 or more admissions or presentations for those chronic diseases. The accompanying that flag is an alert that also comes up in most of the PAS systems across the state now, that actually comes back to the CDMP, that tells them in real time that someone's gone to the emergency department, and then that can be tracked as to whether or not they go to be admitted into the wards. If that's the case, then the ideal is always that discharge actually starts at that admission, and that the chronic disease management program and their involvement from a care coordinator point of view, or alerting the other members involved in that person's care, is actually up to date with that recent admission. We also have there's electronic discharge summaries that are in some areas, but then there's also the ability where there's visibility of the systems that you can actually promote that electronic discharge summary, making sure that the GP gets it, or in particular the Aboriginal medical services that don't necessarily have that. Like a lot of these require the system sitting in and the secure messaging and the enablers that sit in behind, but it is there's across the state, there's some areas more advanced than others, but the beauty of CDMP is that having that involvement in right across the state is that the sharing of ideas that occurs and the linking of people together to talk through opportunities to improve is always there. We do have risk stratification. We do look at those clinical priorities, those reasons that potentially people will readmit back to hospital, and once that's known for a person, then that obviously forms a flag as well, and there's work done with that. I really like the 8P. I think that was I guess in some ways that was where my head was wobbling in terms of, yes, that's a bit validated, but there's other things there as well, and the pitfalls. The service itself, the models are varied, depending on, as I said earlier, infrastructure, the region, the locality, what people had to start with, what people gained along the way, what they've built on, reasons to improve. Some have actually gone back to total redesign of the program, and I think that just shows, how, because of this being such a wide thing, touching so many areas of the sometimes difficulties but also opportunities that have arisen. To give a broad brush around how CDM has been rolled out across the state, it has been around substituting rehabilitation programs, or supplementing, I should say, not substituting, supplementing rehabilitation programs, particularly around self-management and the health coaching component that might sit at the end, being able to run extra rehab programs, really being able to look at the different ways in which rehab clients could be identified. We have there's patient action plans. One of the aspects around this shared care plan is around the GP management plan, and the team care arrangement was our starting point, but it is actually trying to incorporate the specialist plans, but also the patient's plans, the patient's goals, and what they need to establish those goals, as well as trying to get those escalation plans in as well. So that's the work in terms of readmission in particular. Health coaching has been it's around supporting the disease-specific and lifestyle changes and changes in behaviour that need to occur, but it's also around that whole health support, health literacy, understanding the disease, patients knowing, carers knowing. So that's been a really huge component of the chronic disease management program, and that health coaching from a LHD perspective has been something that people have chosen to do in-house, but there's also been an ability to do that externally. And as we come further down the triangle, the use of the Get Healthy line from New South Wales is also part of that, particularly around that's addressing lifestyle change. We do follow-up. We've learned a lot from 48-hour follow-up. There's been in some of the LHDs where they perhaps had some strengths around maybe their Aboriginal programs, if they had centralised contact services, or depending on how their Aboriginal health might have been structured within chronic disease programs generally, those linkages were made fairly early. They're now developing more and more across the LHDs, and so the 48-hour follow-ups taught taught LHDs and chronic disease quite a lot about the value of following up people and asking those simple questions. I particularly like the point when we talk about our systems, is the point that Greg made earlier, though, is the real need to have the documentation around that, because there's a lot of follow-up that goes on, and there's a lot, people hear that and think, oh, that's a great idea, and so you've got specific programs following up and things like that. So what we don't want to do is all of a sudden, we've got our patients now just constantly picking up the phone to someone, ringing to find out how they are. So that documentation that's occurred and the result of that, I think, is really a very pertinent point that was raised this morning. Some areas did have strong contact centre models that are, whether it be referral and access, it may have been for their community services. What the strength in some of that has been around being able to have that partnership, that surveillance, that ability to have that patient services centre where it's an inbound, outbound, patients can ring, it gives them a central point to go, also GPs and service providers as well. But it's at that level, when you're working like that, there's a great ability to be able to look at your systems and have flags going so that you actually know what's going on in real time, which is really important. And then, of course, there's an ability to recall. You can always encouraging patients to, if you can, or their carers, to know what those signs are around deterioration and getting onto that fairly quickly. The other thing that CDMP is, because it is large, statewide, funded right across, is that we've actually been able to start to look at, like the workforce, some of the workforce issues, and that's around training and education across the sectors. So there was some of the enhancement funds actually provided health coaching training, and that was able to be run in primary care as well as community health and some of the disciplines within the acute care sector. It is about that chronic disease management. What does that look like? What are the skill set that's needed for clinicians as they go out and are seeing people around the conversations they have? And of course, it's moved into the advanced care planning. So there's close alignment with palliative care network and services, having conversations with palliative care teams around providing that palliative approach to chronic disease, and then arming people with what they need to do that. So CDMP does champion, and in some areas have worked extensively in trying to champion that advanced care planning conversation and having that at the beginning. We do have an evaluation. This is the last slide, so I'll stop talking to you. But we do have an extensive evaluation going on. It's in progress. We've had it's going to look at service utilisation. We have had a process evaluation as well in 7 LHDs where they've actually gone out and there's been quite extensive interviewing and looking at things from governance to partnerships to the models, and there's a draft report at the moment with that coming, and then a quantitative measure. We've been very fortunate in so far that we've been able to establish a public health register, of which there's just over there was 47,000 entries on that. It's been cleansed, and there's just over 30,000 people on that register. So that will be able to, that's part of forming that evaluation, and that will be an ongoing thing. So there will be an ability to look at that further down the track. We've also from the chronic disease program, there's been a self-assessment tool developed as well, where LHDs and the specialty networks will actually be able to map themselves by a matrix back to the service model and how they've provided it to from a quality improvement point of view, and all the questions that fall in around that. And LHDs have also collected information themselves around their perhaps drilling down to one cohort that has certainly been able to demonstrate where there's been a decrease in both the presentations and length of stay, and we would be looking